Okay, let's talk about status epilepticus. Say you're working a shift in the ER and an ambulance brings in a patient who is seizing. By the time he gets to your emergency department, he's stopped. However, the nurse calls you back to the room shortly after that to tell you he's seizing again, Doc. What do you want to do? First of all, what's the definition of status? It used to be a long time ago that we would define it as 30 plus minutes of seizure activity, or 2 or more seizures without waking up in between. So here's a question I have for you. Are you really gonna wait 30 minutes before you treat this guy as status epilepticus? No, of course not. You're gonna start treating him right away. Now, most seizures last less than a minute, and so the new definition of status is greater than 5 minutes of uninterrupted seizure activity. Or, again, 2 or more seizures without waking up in between. The thought behind this new definition is that by the time you've already reached 5 minutes, you're already several standard deviations outside of what a normal seizure is going to last. And the longer you wait to treat a seizure, the harder it's going to be to break it. So let's say our guy started seizing. We're going to start treating him. Let's just call him status epilepticus. As with all patients in the emergency department, we should always start with our ABCs, or our primary survey. But let's add a couple new letters here. A, B, C, D, and F. Of course, we want to make sure the airway is okay. Maybe they are obtunded or vomited during the seizure. You might need to intubate them. Not going to be easy to intubate someone while they're seizing. Next, breathing. Seizing patients tend to be hypoxic, and so give them some supplemental O2, perhaps by a non-rebreather mask. Finally, circulation. Initially, at least, patients with seizures tend to be hypertensive. However, as we'll talk about later, their pressure will drop eventually, so keep an eye on that. Now, the next two are very important. These are D and F. D stands for dextrose. Hypoglycemia can easily cause seizures, and this is something we can easily fix, so check a sugar. And F is fetal heart tones. The treatment of pregnant patients with intractable seizures is completely different, and we need to know that from the start. Now, you're likely not going to be able to get a urine pregnancy test while they're seizing, so either send a serum HCG or put the ultrasound probe on them and looking for fetal heart tones. So what's the first med you'd use? The first med we always go to is benzodiazepine, either Ativan or Valium. This is 2 to 4 milligrams, about 5 milligrams. The difference between the two is that Ativan can be given IV, whereas Valium can be given IV, IM, or even PR. So if you don't have IV access, Valium is a great go-to drug. And you could repeat this. I would probably repeat this 2 times. Now, if I have someone in status, I know that time is important. So while I've given the first dose of Ativan, I'm already thinking ahead to what's the next drug that I might use and ordering that. So what's the next drug? Phenytoin. That's Dilantin. So as the first dose of Ativan is going in, I'm calculating the dose of Dilantin that I'm going to need to give, giving that order to the nurse so that the pharmacy can send it down. So when I need it, it's available. If I wait till 2 doses of Ativan have failed and then have to wait for pharmacy to send it down, well, that's just a waste of time. Now, Phenytoin is not water soluble, which means it has to be mixed in polyethylene glycol. And this is arrhythmogenic and limits the speed at which you can give this drug, mainly 50 milligrams a minute. You can't give it fast, and we just talked about time being very important. So Phenytoin is somewhat cumbersome to use. However, there's a different formulation of Phenytoin, which just adds a phosphoryl group onto the drug, and this makes it water soluble. Now you don't have to mix it in polyethylene glycol, and so you could give it 3 times faster. This is phosphenytoin. Now remember, this stuff needs to come from the pharmacy, so while the first dose of Ativan is going in, calculate the dose of Phenytoin you're going to need and order it then. So by the time the second dose fails, you're already set to go. Let's say this fails too. What are you going to do if Phenytoin doesn't work? What's the next step? Usually then we go to Phenobarbital. And this also has some effects we don't like. It causes respiratory depression and it causes hypotension. It also has a very long half-life. All these things make it a little bit more difficult to use. Valproic acid is great for patients who are already on VPA but they're non-compliant. Or maybe they have a dilantin allergy. Now there may come a time soon where valproic acid is actually going to move ahead of phenobarbital in the treatment algorithm. Some people probably already do that. Now at this point, if your patient is still seizing, well, we have refractory status epilepticus. So what do? Well, the next drug you'd go to is Versed. Yes, another benzo. But Versed has some different characteristics which are helpful. The main one being that it's got a much shorter half-life than Valium or Ativan. So this allows you to titrate it. You could give them a drip. It also causes less hypotension. If that doesn't work, then we go to Pentobarb, another barbiturate. And again, this has a shorter half-life and so allows you to titrate it. The idea here is to induce a Pentobarb coma. If your patient is still seizing, another drug you could try is propofol, which supposedly will stop all seizures. And at this point, if your patient is still seizing, man, these are some pretty refractory seizures. I'd at least consider INH toxicity. And the treatment for this is vitamin B6 at a dose of 1 gram per 1 gram of INH taken, or a max of 5 grams. It's a fairly harmless treatment, so you may as well just give 5 grams of B6 and see what happens. If it helps, great. If it doesn't, then oh well. Hopefully by this point you've stopped the seizures, and if not, you've consulted neurology to help you manage it further. But you've already got the patient on 2 drugs which you can titrate, Versed and Pentobarb, and hopefully get them to stop seizing. So let's review the drugs we've given so far. First drug you're going to give with your seizing patient is a benzo, either Ativan or Valium. And you can repeat that dose, but after the first dose, I'd probably order my Phenytoin or my Phenytoin because I don't want to be waiting for it when I need it. So give a dose, give a second dose, see if it works. If it doesn't work, give either Phenytoin or Phenytoin. Now, back when I trained, Phenytoin was so expensive, that's why we never used it. But at this point, you can give it faster, so I would say the better drug to give is Phenytoin. If that doesn't work, jump to Phenobarbital. 20 mg per kg. Again, next, Valproic acid. Now, if your patient is still seizing, you got a refractory status, and so you got to put them on something that you can, on a drip that you can titrate. And the drips you could use are Versed, Pentobarb, and propofol. And consider INH toxicity in these patients with refractory seizures, because this is something that's easily correctable. So let's say now that you were able to stop the seizures. What are some of the complications of status epilepticus? So remember that this is a state of not only a lot of neuronal hyperexcitation, but a lot of muscle contraction as well. And that has consequences. First of all, you may have muscle breakdown, and so you want to watch out for rhabdo. So check the CPK and treat accordingly. Also, with muscle cell breakdown, you're going to have hyperkalemia. That also needs to be treated. And the lactic acidosis. And hyperthermia. And remember, this is a very hyperadrenergic state, so they're going to be shooting their catechols out, and that's what made them initially very hypertensive. However, at some point these are going to be depleted, and your patient is going to become then profoundly hypotensive. Just keep an eye out for that and treat that accordingly as well. You may need to support their blood pressure. At this point, your patient is likely intubated and on several drips, and probably not outwardly seizing anymore. However, one thing you do have to worry about is subclinical status epilepticus. Actually, the new term for this is non-convulsive status epilepticus. And this patient needs a call to Neuro to get an EEG. This may be the only way you're going to know that this patient is seizing. In fact, you should think of non-convulsive status epilepticus in all of your patients with altered mental status. So someone who comes in obtunded, they might be actually seizing. Now chances are you're not going to be able to get an EEG in a timely manner, so what you can do is give a test dose of a benzo. Now this may seem counterintuitive. You got someone who's already out of it and you're going to give them a sedative, but that's exactly the point. If they're out of it because of non-convulsive status epilepticus, this may wake them up. So give them a test dose of the benzo. If they wake up, it was non-convulsive status epilepticus. If they don't wake up, I would try a second dose. If they still don't wake up, it still can be non-convulsive status epilepticus. You got to get that EEG while you're working them up for other causes of altered mental status. There's a lot of complications of status that you might run into after you've controlled the seizures, namely rhabdo, hyperkalemia, lactic acidosis, hyperthermia, and even hypotension. While your patient is sedated and intubated, consider non-convulsive status epilepticus and getting an EEG. Remember that in your patients with altered mental status, you might want to try a test dose of a benzo to see if non-convulsive status epilepticus is what's causing it. Okay, and that's it for this seizure thing. I just wanted to say that I got some of the information from this thing from Amla Matu's EMcast.